Dominic Zerlo, and I am the chair for the Overdose Prevention and Pain Management Council, as well as a director at the New Mexico Department of Health for the Medical Cannabis Program Division. And so first thing I'm going to go ahead and do is do our roll call and attendance to make sure that we do indeed have a quorum. This is going to be just the individuals who are council members. As there are some people who are still going on, I will ask at the very end if I miss anyone, because the list does jump around a little bit on me. So I just want to make sure that I catch everybody. So we'll start. Neil Bowen.
Present. Thank you.
Thank you, Neil. Welcome. Scott McFall.
Present.
Thank you, Scott. Steve Jankowski.
Present.
Thank you. Monica Arencon-Smith. Okay. Sharan McCracken.
Present. Good afternoon, everyone.
Good afternoon, Sharan. Brandon Taylor.
Present.
Thank you, and welcome again, Brandon. Charles Schumacher.
Present.
Thank you. Darcy Pope Wyatt.
Present.
Thank you, Darcy. Leslie Ann Hayes.
Present.
Thank you, Leslie. Welcome. Ernie Dole. Okay. And Andrea Maloney. Okay. Elizabeth Dyer. Mackenzie Enriquez.
Present.
Thank you, Mackenzie. Welcome. Joanna Katzman. Randall Starling.
Hi, Dominic. Present.
Hello, Randall. Thank you. Phil Feudy.
Hi, good afternoon.
Good afternoon, Phil, and welcome. Jennifer Weisberg. Okay. Brandon Warwick.
I'm here.
Thank you, Brandon. Welcome. Elizabeth Boyce.
Present.
Thank you, Elizabeth. Welcome. And Liz Lacouture.
Hi, Dominic. I'm here.
Hello, Liz. Thank you and welcome. And I'm just going to go back really quickly to see if we have anyone else who has joined that I've missed that is on the council. Is there anybody who has since joined or is joined by phone? Okay, so we do have a few other people who are on the call. As we started to do, we're not doing introductions of everybody who joins in the beginning just to save time. But if you do have questions or as we move forward and have not introduced yourself, please just introduce yourself. Let us know who you are and where you are from. So the first item that the next item that we have, oh, and by the way, we do have a full quorum, I should mention, and we actually have quite a few people on today. So that is great to see. So our next step is actually to look at the agenda. And let me just share that very quickly with everyone. And if you have not seen it, it is also in the invite as well as on the website. And I'm hoping everybody can actually see the agenda right now. So the review of the agenda, the one thing that I would like to do, because we do have a couple of people who may need to leave a little early. So I would actually like permission to be able to have the fentanyl subcommittee do their update after the other two rather than in the very beginning, just because the other two groups do have recommendations that we need to review and look at. Do I hear any objections for that?
No, and I second it.
Thank you, Brandon. I appreciate it. So right now, do we have any objections to accept the agenda with that one change with the fentanyl subcommittee at the end of the subcommittee group? No objections, so we will move forward with that passing. I do see that Joanna Katzman, you've joined us as well. So thank you. Good to see you. I haven't actually seen your face in a while, so it's just great to get to see you.
Sorry about that. Thanks, Dominic.
No, that's okay. It's great. Okay, so our next item is the review of the minutes from the meeting in May. Now, unfortunately, we did not have a quorum for our meeting that we were going to have in between. And so here are the minutes from May that we had. I'm hoping everybody can see the minutes now. Are the minutes showing on the screen? Yes. Okay, perfect. And so we did during that meeting, we had a quorum. We introduced Paul Maldonado, who is going to be helping us with regard to the committee. He is actually on vacation today. So Josh Swatek has actually agreed to step in and help me to keep things on track to make sure I don't go too far off track today. And that we moved over to the Google group, which I know that created a little bit of confusion, but it seems we are back on track at this point. And then the main items was, well, I think you all can read them and you have had them for at least a week at this point. So what I will just ask is if there are any changes or corrections or a motion to accept as is. And I'll give everybody a few moments to be able to read through and see if you have any changes or concerns. Okay. Are there any changes or corrections that need to be made? Can I get anybody to move to accept these minutes?
Move to accept the
Motion to
minutes.
Oh, well, I heard several people move to accept, and so I will take that as an accept in a second. So at this point in time, are there any objections to accepting the minutes as is? Hearing no objections, we will go ahead and accept those minutes. And so the next item is council membership status. And it's, again, only 1 minute because, once again, we are still at 21 seats and all of the seats are filled. And as we can see today, most individuals were able to make it today. I have had a couple of people who are not due to travel or a few other conflicts, but we do have most individuals here on the council. Do we have any questions with regard to the council membership? Now, we've been having this on because there were some questions and some concerns regarding council membership last year. We have left it on. Is everybody okay in the future if I leave council membership status off unless we have changes? Okay, and that doesn't, by the way, doesn't need a vote. That's just a, is it okay for me to do that? All right, we will do that then. So our next step then are the subcommittee updates and recommendations. And so we'll go with the methamphetamine subcommittee first. I do have an announcement with regard to that, and that is that Alicia Campbell, who had been chairing that subcommittee, has actually left the Department of Health and has moved to another position elsewhere, and so is no longer a part of this group. But she has stated that if we do have questions, concerns, and if there are ways she can help, we can reach out to her. But I would really like to thank her because she's done, especially over the last year, a lot of work with regard to the items for the methamphetamine subcommittee, especially, and has really, I think, the three recommendations we're looking at, she had a lot of input and really was instrumental in helping to craft those. So I would just like to definitely thank her. Is there anybody else who's here from the methamphetamine subcommittee who would like to say anything with regard to that? And Alicia? No. Okay. Well,
Catherine Lowry, Department of Health, Overdose Prevention Section Head. I will just say I worked with Alicia on one or two of these, and yes, we're very sorry to see her go, but Texas Public Health is getting one of their own back, and I actually know where she's going to work, and they're so excited to have her. So, but yes, she also has conveyed she is always happy to answer questions, and I'm going to touch base with her when she's back in town in a couple weeks. So, yep.
Thank you, Catherine. And yes, it's good to know that our neighboring state is going to have a great person working over there. Which is not to mean they don't have other great people, by the way. I'm glad she's still within the region.
And Dominic, this is Philip. Are there actions yet that need to be taken on those?
Yes, Phil, the next step is we actually have to review and then vote on the recommendations. I know we did in June, we did bring them up just to talk about them a bit, but because we didn't have a quorum, we weren't able to do anything regarding them. So that's actually the next step. So unless there's anything else, I'll move to that first recommendation from the committee, which is about contingency management. And so let me share that on my screen. And again, that was included, all of the recommendations for today were included in the invites, or they can be found on our on the website. So you can always look at that as well. And pardon me while I switch screen sharing. And the first one to come up is the recommendation on contingency management, I believe. Let me make sure I'm sharing the correct screen. Yep, here we go. Can everybody see that screen on contingency management? I'm going to increase the text a little bit, so pardon me for a moment. Okay. And so the recommendation on this is, it is recommended that Medicaid and insurance carriers within the state should be mandated to cover contingency management as a treatment option for stimulant use disorders. Is there anybody from the methamphetamine committee that would like to say anything with regard to this particular recommendation? Brandon?
Yeah, 1 second. I'm sorry. I'm eating my lunch while doing the meeting.
That's not a problem, Brandon. We completely understand, and just to let everybody know, we also have been joined by Andrea Maloney. She is on one of the phone numbers and just can't switch over to speak at the moment. So thank you, Andrea. And yes, on any of the votes, if you have any questions, just send me a message and I can relay it. So Brandon, please go ahead.
All right. And Ernie Dole said he was going to be on here hopefully shortly too.
Yes.
So just as a summary, contingency management is a type of therapy that's built on it really goes back to the basis of B.F. Skinner and intermittent reward for good behavior. I think as the council knows, we've been having a growing methamphetamine problem that's really skyrocketing. Growing probably isn't the right word for that. As far as effective treatment options go, contingency management as a course of therapy is hands down the best option that we have at this point, and it's largely not covered by insurances. The cost I think we put in here is probably 120. I think that's a little on the low side, but nevertheless, the only other in a comparison economically, the the medications of naltrexone and bupropion, when used in one clinical study of 120 some patients, had a retention into treatment of about an improvement of about 10%. Contingency management more than doubles that with a tenth of the cost, roughly. Nora Volklau, whether or not you like her or respect her or agree with her, she is the acting and has been for about better part of the decade in charge of NIDA, the National Institute on Drug Abuse, which is providing funding. In the last week, she indicated that NIDA would no longer be funding contingency management, and in reading that, that's because she feels that the data is very robust at this point, and further adding to the literature isn't going to overcome the issue of the lack of insurers covering it. So I think we need to have it approved for methamphetamine, but I would also anticipate that it would be benefit and the data out there. And if Neil Bowen has some additional information too, I would welcome his input. But it's been shown in opioid use disorder as well as other addiction disorders as well. If you guys have questions, I'm happy to do that. I'm also happy to talk about the pilot that we've been participating in at ASAP with money from HSD.
Brandon, can I make a couple of comments or questions? It's Steve Jankowski.
Go ahead, Steve.
Is that all right? Yeah, a couple of things. One is I totally agree. I think the evidence is overwhelming that this works, so I'm not arguing with that. I thought the issue was giving people money was a compliance issue, and that was something that people had indigestion around, because as far as this being a therapy, when someone bills for psychotherapy, you don't have to say the type of psychotherapy you're doing. You know, you can do CBT, you can do motivational interviewing, you can do, supportive, whatever. But the issue with contingency management, I thought, was where do you get the money and how do you overcome like compliance issues? So as you probably read, what some IOPs would do is they would have a raffle or something, and you could win a raffle or something, and it would have the same sort of dopamine kick or whatever, I guess, for winning when you did your lab tests and they came back clean. So I thought that was the issue, not so much that, it's a training issue, making sure people that treat addictions understand what contingency management is and how to execute it. And apparently there are some online, like web-based programs that provide that sort of support. But yeah, coming back to it, I don't know that this is something that we have to mandate as a treatment, because it just would fall under a bill for psychotherapy. I thought the issue was getting past the lawyers and the compliance people in giving patients money.
Yeah, I think
Steve?
I think as far as just giving people money, there's at least one FDA approved app for it out there that does contingency management. It doesn't have to be just straight up money. It can be prizes, gifts. Insight to me at ASAP in our pilot program was that candy and art supplies got rapidly replaced by personal hygiene products. And I don't know, I'll call it white privilege, but I don't think VO5 shampoo should be a reward for anything.
Gotcha. Hey, Brandon or Steve, or anyone with expertise in this area, can I ask you a quick question? It's Joanna.
Go ahead, Joanna.
What's the, I don't know this literature at all, so I'm just very naive, but what's the long-term outcomes with with contingency management with methamphetamine use disorder?
So again, it's improved retention and treatment. I haven't seen any survival data, but again, I just bring up
or recidivism. Yeah,
and it's much better than that that we've got for naltrexone and bupropion at much less cost. Too, and I think it's, you know, as we go forward here, we've got to have something that primary care physicians can be doing in their office, and I think with an FDA-approved app, with some of the and basically you get points. There's a couple different ways. One's a raffle that Steve had described. The other is as you get a certain number, you get points for. No, I'll just use my 10-year-old son. He gets dojo points for good behavior in the 5th grade. And then you can turn those points into a prize. I mean, that's what I'm at. That's really what I'm doing for the patients. And then I
hey
just wanted
guys,
to
this is
acknowledge that
Ernie.
Neil's got his hand up.
Yeah, Neil?
I'm pretty sure Phil had his hand up before me. I'm happy to talk, but I would give Phil precedence.
Well, I think you and I maybe were going to say about the same thing. So you can go ahead and begin.
So maybe we were. I completely agree about the clinical perspectives that have been presented. I think contingency management has been clearly demonstrated to be one of probably the most effective treatment for methamphetamine use. But I wanted to point out that it's not just the lawyers; it's the Office of Inspector General and, you know, within the federal government that has prohibited the Centers for Medicaid and Medicare Services from paying for this historically. Now in April, they provided a little bit of a gap, and California managed to get in their 1115 waiver approval for a demonstration project with contingency management for methamphetamine use. But they're the only state that I'm aware of right now who's allowed to do that by CMS. So the language of the recommendation that, you know, be mandated to cover contingency management, mandated by whom? Because nobody in the state of New Mexico can overrule CMS. And we can put it in a request for a demonstration project within the state, but right now we simply cannot have it paid for by Medicaid. And the problem is anti-kickback kind of regulations. The concerns are exactly that, the monetary reimbursement piece.
Hey guys, this is Ernie. I just want to let you know I'm on the call.
Thank you, Ernie. Appreciate it. Okay, and then Phil, did you have anything additional?
Yeah, thank you. That was about 50% of what I was going to say. Thanks about the efficacy with that. You know, with opioid treatment and methadone and buprenorphine being drivers of that, you know, there's already sort of incentive for people to stay engaged in treatment. But contingency management has been shown to be very effective with stimulant use, methamphetamine, cocaine. What I was going to say is in the reimbursement piece on there too, I don't think we're necessarily talking about cash incentives with that from the work that I've been doing to incorporate contingency management into our treatment programs with the Mountain Center. It's just we have a dollar amount of value, $75 per individual per year is what we're allowed to spend. So, and then we have to get approval for the things that we're going to use as incentives in there. But I don't think that if there's no mechanism to mandate contingency management, there's no mechanism to convert, I think, Medicaid dollars into cash incentives for people to attend. So, clarification. I do have one other thing to mention, but at the end. So.
Okay. And what I was going to just say, Phil, is so what you're asking is maybe to just do a modification here in the features to say with at least a minimum of $120 in incentives or equivalent items. Does that sound?
I think it would be like a maximum value, right? $120, at least a minimum of $125. Yeah.
maximum value of incentive prizes or gifts or whatever rewards is probably the best way to put it, so that it's clear that there's not $120 of cash that's being
Right.
you know, on the table, as it were.
So I just wrote it as with at least a minimum of $120 in incentives or similar value in other items per participant per year. Does that sound good? Is that any objections on that? And then Josh actually had a point. Josh Swatek, if you can, would you like to
Sure.
raise your point?
Yeah, absolutely. So if the case is that, you know, it can't be mandated that we say that we have Medicaid coverage, like as Neil was saying, maybe we should just change this as a request to put it in the 1115 waiver, as opposed to telling CMS what to do, since we can't. Wouldn't that be nice though?
And Neil, that sounds good to you as well, as from your nodding and hands in the air?
Yeah. I think that's the better way to approach this. Yeah.
Does anybody have any objection on that? Okay, so let's see. I do need just a little bit of help with the wording. What should we say on that? Neil, what would you think would be most appropriate?
Should pursue waiver authority to provide contingency management treatment for substance use or for stimulant use disorders. Yeah.
How does that sound? There we go. Is that appropriate, Neil? Or at this point, should we be taking insurance carriers out?
Well, in general, and Liz might be able to speak to this more than I, but in general, the insurance carriers follow Medicaid, not the other way around.
Okay.
Or Medicaid and Medicare. Yeah.
That's right. No, as long as it's in the waiver and among the list of benefits, we would cover it.
Okay, so we could take the insurance carriers or just leave it language there just to emphasize that a little? Yes.
I would leave it myself.
Leave it. Okay.
Yeah.
So any objection to this change in the language? Okay.
Can I just ask one more question given my naivete, given methamphetamine or stimulant use disorder and contingency management? Let's say
Absolutely.
let's say a patient is doing well on contingency management and they're in some sort of remission, and they're doing well. To stay in remission, or I mean, once they're kind of thinking more clearly, do they then benefit from some sort of psychotherapy, be it, you know, CBT or some sort of psychotherapy, if you will? Or do they just only benefit from contingency management for the duration?
No, you're exactly right, Joanna. I think they transition into, and there's been interesting evidence accumulating about community reinforcement approach for that, so that they find the intrinsic reinforcement in living a life without that instead of needing that external reinforcement.
Right. So that's what I was wondering. So is there something in here? Because I didn't have a chance to read this whole thing, but should there be something in here to suggest that, like, if the patient is doing well, then the recommendation would be then the patient move forward with behavioral health interventions that fits their needs? That's just a wonder.
Well, the thing is, that's already covered. What we're trying to do here is get contingency management, which isn't covered. That's sort of the focus of this, is to get the thing that's not covered. So.
Okay. Thanks, Leslie.
Right. And you know, this is a model. So if you go online and Google this, it will come up, and then there's two different structures, and it's sort of considered entry level. And then the reinforcement, depending on which way you go, is you know, after someone completes their initial thing, and then you say, you know, we'd like you to go enroll here or something, and then the person goes and does or meets with a therapist or something and comes back, and so there's like tiers and things connected to it. So,
and if I can add it, contingency management is a tool in a comprehensive treatment plan. So you'd be going, like, you don't bill for contingency management, you bill for IOP or you bill for psychotherapy, you know. So this is just a tool in the box to help retain people in the beginning and encourage them to do their urine tests and have clean urines or show up for meetings or whatever.
Okay. Are there any other questions or comments? Otherwise, we'll go to Phil, because I know Phil had something at the end he wanted to say. Phil, go ahead.
I don't want to like dive us into controversy and stuff, or some of the language things stick out to me right away, and I'm curious about right in the beginning, methamphetamine related overdose versus methamphetamine involved death. And I've noticed a few places it switches back and forth between substance use or disorder and substance abuse. I'm just curious if that is important to anybody.
I hadn't noticed that. Thank you for bringing that up, Phil. I think it should be the same. I will, and I would, yeah. Substance use disorder is the preferred term, as opposed to substance abuse.
Phil, where does it say substance abuse? Can you direct me? Because I'm missing it.
I don't have it really. Somewhere it says, I believe it says something of drug abuse treatment.
Yeah, the beginning of the second paragraph. Research has shown positive results to this intervention with drug abuse treatment outcomes.
There we go. There we go.
And in the very beginning, I would suggest rephrasing that as methamphetamine involved death, as opposed to, yeah. Something along those lines.
Great, I've got that. Okay, any others? Okay. If that is the case, then is there a motion at this point from anybody to accept the recommendation as amended?
I'll make that motion.
Okay.
It would be my honor to second Steve's motion.
All right, thank you, Brandon. And again, unless there is objection, we will consider this unanimous. Are there any objections? Giving people a moment in case they need to get to the keyboard or change it. Seeing none, we now have a recommendation. Congratulations, everybody. And we will get that one moving forward. Let me switch my screens. Please give me a moment to switch over, and we'll move on to our next one. Sorry, everybody, my computer's being a little not wanting to switch over. I think it's just an effect of the delay of closing one window.
Maybe your computer needs some stimulant treatment.
I think it probably does. Okay. I believe it should be showing at this point. To cover medications prescribed by physicians for stimulant treatment. And let me just get the view a little bit better. Is that what everybody is seeing? Okay, great. So, and again, is there anybody from the methamphetamine committee who would like to speak regarding this recommendation? Well, while people think a little bit about it, I will read the recommendation itself. It is recommended insurance carriers within the state are mandated to cover medications prescribed by physicians for stimulant use disorder that have shown to be effective, are still in trial, and have otherwise had an improved outcome in reducing the use of methamphetamines. Neil, you have your hand up. Go ahead.
Just a question about, when I first read this, I thought that was a list of things that shown to be effective or are still in trial. But is this implying that are shown to be effective or are in trial and have promising, solutions? Because I think we'd have trouble mandating to insurance carriers to pay for things which are in trial and don't have a clear evidence base yet. And I might just be misreading the language. That's why I'm saying.
Yeah, I had similar issues with this in that naltrexone and bupropion are covered. They're not restricted in any way. They're generic. A physician can order those and try them as long as there is some sort of off-label support. Otherwise, you might get in trouble with the medical board. I'm a little concerned about mandating something like Vivitrol. I apologize, I haven't looked at the evidence around that, but it's like $1,500 or something a shot. And so, we do have to think about the cost of things that aren't well established as a treatment. So I would prefer to do the normal route on this, that if it looks like there's enough evidence for Vivitrol to be effective, that be taken to the formulary committees of the insurance companies. And if there's enough evidence, then it'll be approved and it will be covered. But and then I have a global comment that in general, we really shouldn't legislate, we shouldn't mandate certain types of care without giving it a lot of thought, because the science changes, we want flexibility and we're supposed to be stewards of resources also. So I was concerned about this recommendation because I think half of it is moot because those medications are available. And the other half about mandating coverage without going through the normal routes of vetting, the effectiveness of some of these medications troubles me.
For what it's worth, I second Neil and Steve. Although, yeah.
Okay. Do we have other comments, other concerns?
This is
go ahead.
I was not been on this committee on and off, and I wasn't part of drafting this, but wasn't part of the concern it was attempting to address that getting prior authorization on perhaps offering this route to somebody has been problematic with insurance carriers?
I would guarantee that there would be pushback on Vivitrol purely for stimulants because there probably isn't enough evidence for that yet, and it's expensive.
Steve, just supplementing your knowledge, the Vivitrol or the injectable naltrexone is what was used in the clinical trial that they're referencing. And it goes back to what I said, on the contingency management point on why contingency management was 1/10 of the price.
So I would prefer, rather than like a legislative thing, is again, take the drug to the formulary committees and have them evaluated medically. And if there's enough study and evidence there, it'll be approved.
And if you scroll down a little bit, Dominic, there's mentions of some other medications there. Any comments on that? Atomoxetine, etc.
Couldn't guarantee it. There might be pushback on atomoxetine I don't know. So I'd have to look at what the rules are. At least I work with press, so I don't know what the formulary rules around that, because that would be maybe a little bit off the ranch.
All right. You're being a little intrusive right now. Dav?
So are there any other concerns, questions, comments? And it sounds like there are actually quite a few already that have been raised with regard to this. So my question at this point would be, is this a recommendation that is actually ready to be voted on, or does it need to be returned to the subcommittee for additional work and possibly redirection from what I'm hearing?
I would vote for the latter, obviously.
Yeah, so would I.
Okay. So I don't think, if we're just sending it back to the subcommittee, if there are no objections, we'll send it back to the methamphetamine subcommittee for additional work. Are there any objections to that or to this motion? Well, again, it's not really a motion. We just need to see about doing that.
Yeah.
Okay, I don't hear any objections. So we will go ahead and do that. All right, let me just switch screens again. And the next one is the recommendation, and hopefully you can all see this one at this point, should be the recommendation on that there be increased investment in mobile outreach van units in each regional health district for the purpose of responding to substance use crises as mental health issues and for delivering harm reduction, overdose prevention, and related medical services. And anybody from the committee who would like to speak on this?
This is Philip again. I did work on this one. Both it was Alicia and Andrew Knox who did the majority of the work, I believe, on this. And I can't remember now. It's been a while. There's somebody else on the call here today that I'm forgetting. Please speak up.
Oh, Phil, I worked on this with you all. This is Catherine.
Oh, that's right. Hi, Catherine.
Yeah.
I know I forgot you last time too. I apologize on that. So yeah, I think this was, we put some care into this, and it came out of, I think a place that there's just areas that are underserved in general with medical and or crisis services, something a little bit beyond what we've been able to do in limited areas, like with harm reduction, and based on lack of access, increases in homelessness, etc., and getting folks out to being able to get services to people who otherwise do not have access. Thanks. And I see Andrew's got his hand up.
Yes, Andrew Knox.
Hi, everybody. Andrew Knox here, a viral hepatitis coordinator for DOH on the hepatitis and harm reduction team. One of the things that we have as part of our program is, the vast majority of our services are delivered 8 to 5 during work hours, and there's a little bit of outreach downtown in Albuquerque. And so this would enable us to expand those hours to weekends and evenings a little bit easier, and also be able to take them to areas that just have no service. We do have one mail order service where people can get their syringes and works, but there isn't anything really to address people who are having crises and need more services than just harm reduction. So we think this is it's a well-supported strategy, and we just don't have the money right now to fund those types of services that are mobile. We can do it in cities, but really not take it out to areas where there's high overdose risk, and then also need for harm reduction services.
Great, thank you, Andrew. And Neil, you have your hand up.
Yes, I think this is a great idea, increased investment in mobile outreach van units. I would just request a changing in the language because, and some of you may not be aware of this yet, but our 988 Crisis Now model includes mobile crisis teams for substance use crises as well as other types of behavioral health crises. And I would hate to create confusion about who's doing what. So in the recommendation itself, I would just, for the purpose of delivering harm reduction, overdose prevention, of related medical services, I wouldn't eliminate the possibility of responding to a crisis, but we're standing up mobile crisis teams that are designed to also respond to substance use issues already, separately from these kinds of vans.
Okay, thank you, Neil. And could you repeat that, how you would word that?
I would basically just, for the purpose of, and then I would take out responding to substance use crisis as mental health issues. And so it would just go for the purpose of delivering harm reduction, overdose prevention, related medical services. But I'm very open to hearing feedback from the people who worked on this, because I think it's a very nicely crafted recommendation. Other than, I just don't want to create confusion in people's minds about how they get responded to for all types of behavioral health crises.
No, that's a great point. Are there any objections to that language change? See how easy that was, Neil? Okay, so we have that that edit there.
I did see a hand go up though, Dominic.
Oh, did you? Was that Andrew? Did you raise your hand again, or is that a phantom? Okay, no, that's just a leftover.
It just jumped around on my screen.
Joanna, did you have a comment?
Yes, please. I was just wondering if you could briefly go over just one more time exactly what goes into these mobile units. I take it syringe services, naloxone distribution, like brief behavioral support, or can you explain exactly what goes into these units? They sound great, but I just wanted to know exactly.
Okay, yeah, Andrew, Phil, or Josh, would the three of you, because I know all three of you have been involved in this.
This is Philip. I think, and anyone else can augment this. I think that, you know, again, you know, we do have harm reduction, and we do have some programs like ours, for instance, that do go out into the communities and interact with people, but we are actually really limited in what we can do. And I think the idea or the wish list here includes would include combining those services with people who had behavioral health expertise and, you know, crisis management, and also medical abilities to do medical things out in the field as well. So it's a little bit more comprehensive than what most of the harm reduction programs are capable of doing on their own.
I think it was discussed potentially to have nursing staff so they could potentially do wound care. And then even if you didn't have the ability to bring out a mental health professional or an MD, you could do telemedicine if you had the electronics on board. So the medical professional could stay, you know, in their office, but then connect when there was an emergency.
Yeah, if no one minds, the other thing that I thought was really important, and it's great that we have that we have more publications that will be the evidence base for this, was the flexibility that everybody else also mentioned. Again, being able to, as opposed to trying to create more brick and mortar clinics, having the flexibility to go where needed at special events to a particular area as things change, because we know the landscape of substance use around New Mexico also changes. And so that, I think, was really some of the things that Phil and Andrew and Alicia and I were trying to focus on with this. And also the use of peer, in addition to RNs, I think we also, we included peer support workers definitely as, all right. And I love seeing Neil do the double thumbs up. That just makes my day.
That all sounds amazing. that all sounds amazing. One other idea that I had was also adding, just for a thought, would be CHW CHRs, because they are trained in New Mexico and many of them are bilingual, and the CHRs can take care of those, some indigenous communities too. So that's just an idea.
Yeah, and I think, Joanna, that's actually covered, because again, the recommendations don't go into every single detail, but it does talk about how the staff can include. And so I think that's a really great point on that. Okay, are there any other questions, comments, concerns? Sharan, I see you just put your hand up.
Thank you. Can you hear me okay?
Yes.
Excellent. So just in reading the recommendation, without going into all of the rationale, and I don't know if at some point it could be out there just as a recommendation without all of the additional information. To me, it's not clear to whom we're recommending that the increased investment resources go to. Is this going to be basically operated or coordinated by or through a particular program that's spearheaded by the Department of Health and in collaboration with other resources? Like, who are we asking that the money go to? And can that also be put into the clarification, and that, to Neil's point, might make it clear like who this is, and that it's not an intersection with 988.
So Sharan, I can actually answer that. Some of that is because these are recommendations that go to the governor's office. And so this is a recommendation that the governor's office, support that there be increased investment. And at least my understanding was it was left a little bit open on that, so that that the recommendation isn't micromanaging. And so that the investment is just about increasing those services, regardless of what agency or other programs are doing it, but just to make sure that there is an increase in them. And I see Neil was nodding his head yes, so I'm going to take that as at least one thumb up there, Neil. Brandon Taylor, you just put your hand up.
Yeah, one of the facts that I noted in one of the studies, one of the findings was that of those who are classified as needing but not receiving treatment services, 95% did not think they needed to have some type of treatment or services. And, that's one of the roles I think that is so great of mobile outreach, like having worked for the health department as a DPS and driven syringe exchange vans in northern New Mexico. One of the, and I'm sure many others have been involved, here on this advisory council in direct mobile outreach, is that developing relationships with people, regardless, not even finding out whether they define themselves as needing services or not, developing a human-to-human relationship within one's own community and meeting people where they're at without judgment, and ensuring that they have access to secondary prevention of bloodborne infections, ability to prevent infections such as infections related to injections or other types of modalities of routes of administration of drugs. Over time, people will often start to just open up and share thoughts, or start to question themselves openly. God, I used to think I really didn't, I was doing just fine, but now that I look around, I realize that I've kind of like lost this and lost that. I lost my job, and maybe it's time to think about another path or what have you, but in layman's speak. And I think that it's very important. So I'm glad this is something that the governor's office is interested in potentially devoting resources to, because I think it really does help people who otherwise would not necessarily self-define, like the majority of people don't, it seems, who don't access services, as being able to benefit from some type of treatment, including harm reduction. So thank you so much.
Thank you, Brandon. Any other comments or discussion? Oh, Phil, were you trying to say something?
Sorry, I hit the wrong button. I was just going to add that I just recently saw a presentation by some folks from SAMHSA that updated that data. Their 2020 numbers show that it's about 97.5% of people now, and that equals roughly 37 million folks in the country. So things have gone up a little bit since 2016.
Okay, thank you for the update, Phil. Any other comments? Okay, is there a motion with regard to this recommendation?
I'll make the motion
Steve, and what motion are you making?
that we accept the recommendation as written.
Okay, thank you, Steve. And Brandon Taylor, are you seconding?
Yes, thank you.
Thank you, Brandon. All right, and once again, unless there is objection, are there any objections to accepting the motion for this to be the council's recommendation? Seeing no objections, we will count this as unanimous consent. And so give me, oh, and actually that is the last one for the methamphetamine subcommittee. So thank you everybody with regard to that. We're gonna switch now over to the integrative medicine committee. So Michael, I know you were on, Michael Pridham. If
Yes.
you wanna go ahead and get started while I switch screens.
All right. Yes, hello, I'm Michael Pridham. I'm a chiropractic physician in Albuquerque in private practice at Equilibrium Wellness Center, First Nations Community Health Source, and I treat patients at the UNM Pain Clinic. I chair the Integrative Treatment Committee, and we have been meeting pretty regularly. I would like to highlight the work of Dr. Aline Goosh, Dr. Brandon Taylor, and Dr. Yvonne Waston for their input on the recommendations for the Doctor of Oriental Medicine. Also, thanks to the longest serving member and our godfather, Dr. Robert Ryan, for his contributions, as well as Galina Privitskia for her contributions. I appreciate Dominic and Paul for attending our meetings as well, and especially for helping to send out the invitations and the links. If anyone would like to join our committee discussions, please sign up for the Google group. Last week, we submitted our revamp of some of the recommendations that have been voted on by this council over the last just about 10 years. There are numerous guidelines, research articles, consensus papers highlighting the benefits of Oriental medicine and chiropractic medicine, as well as massage therapy and other hands-on modalities. I'm happy to announce that HSD submitted their waiver renewal document on Monday with their intent to add a chiropractic medicine pilot to Centennial Care starting in 2024. So thank you so much to Secretary David Scrace and Deputy Cabinet Secretary Carrie Armijo for their commitment to improving Medicaid, and for specifically for holding the work group with representation from Blue Cross Blue Shield, Western Sky Community Care, Presbyterian Health Services, and the New Mexico Chiropractic Association. HSD will be taking public comment until October 31st, I believe. So it would be great if any organizations could provide statement of support for this pilot project. And then several other states are starting to cover acupuncture, and we are going to continue to advocate for the addition of doctors of Oriental medicine, doctors of naturopathy, pharmacists, clinicians, massage therapists, and others in this program. And thank you to all the council who have continuously supported these recommendations over this last decade. The first one is the first recommendation that was voted on back in 2013. So that kind of puts it all out there, but we had two recommendations just because the amount of research per profession. So this first one definitely includes chiropractic physicians, massage therapists, doctors of Oriental medicine, pharmacists, clinicians, and there it is. Are there any questions?
And just for those who are on the phone and who are going through other, if you can't see the screen very well, again, each of these recommendations is on the website and was also included in the invitation link for the meeting. But just to read the recommendation itself, it reads as, the Human Service Department Medical Assistance Division should consider expanding medically assisted treatment options for persons living with opioid addiction, as well as expand reimbursement options for alternative treatment modalities for chronic pain, chiropractic physician, massage therapist, doctors of Oriental medicine, pharmacists, and pharmacist clinicians. So are there questions, comments? And thank you again, Michael, by the way, for the introduction on this. You do this so much better than I ever could.
This is just a minor terminology thing, but instead of saying opioid addiction, opioid use disorder is a preferred term defined by the DSM-5. I think we should use that terminology. And then it's also under purpose.
I had just copied and pasted from 10 years ago, so I don't know if that was, thank you for that recommendation.
One of the comments that I wanted to make was just how convincing the evidence is about preventing people from beginning opioid use disorder, which would be providing pain management that is non-pharmacologic and or non-narcotic. That's pharmacologic but non-narcotic, and that there is so much evidence that use of chiropractic, massage, acupuncture, yoga, those kinds of things as a first point of pain management helped people to prevent being prescribed a narcotic and starting narcotic or opioid pain management. And that there was also some research that showed that the number one reason why people have an opioid use disorder is from having a prescription originally. I think it was something like 80% is what I saw in some of the data of, opioid use disorder starts with a prescription for pain that is an opioid. So I just think that's really helpful to think about this in terms of primary prevention first and foremost, but then also treatment of people who are struggling already with an opioid use disorder. Again, the majority of them started from being prescribed pain management medications that were opioid in nature, opiates, and helping those individuals as well to have pain relief and to have, in the case of acupuncture and possibly chiropractic, weaning from. So I just think that's really great information and evidence that Dr. Pridham had shared. So thank you so much for including all of that.
Thank you, Brandon. Are there other questions, comments? I know, Brandon Warwick, you had an item.
Yeah, so I'm good with the recommendation statement, but then in the purpose, I think it's going to be more effective, and I've said this at meetings in the past, but that the treatment modalities are aimed at relieving chronic pain.
Yeah, and I think that's what it says in the statement, modalities for chronic pain. But you're saying in the purpose?
And then, I think, and to me, I would be curious what Joanna's comments would be, because she's the pain doctor. I'm an addiction doctor. But to me, there's just the use in chronic pain is huge, and the need for that, and just because the patient shouldn't need a co-occurring opioid use disorder to be eligible.
True.
Right.
And when I look over that, when I'm thinking about that, I just don't want that to be as part of confusion.
That's a good point. I would be happy to take that out.
So my question is, exactly what would the wording be then? And this is for the purpose statement, correct, Brandon?
I kind of agree too on that. It might be better to, these expansions will support increased numbers of providers treating persons
To prevent.
with chronic pain, to reduce the frequency of opiate prescription and thereby reducing the risk of developing opiate use disorder. Something like that. I think that's what you're getting at, Brandon.
Yeah. And Ernie doesn't know how to unmute himself.
Is that what you're getting? Do you agree with that, Michael?
Yeah.
Do you agree with that, Michael?
Very much. Yes.
Yeah, 'cause I'm just thinking, I went for a little bike ride this morning and I just took a little tumble. I'm not hurt or anything, but like I would rather go visit Michael or Brandon, given nothing's broken, than just get a pain pill.
Yeah.
Well, also, right.
I'm sorry. So I'm just trying to determine what wording here, if we can, for just a moment.
I would just like to add in, because I really appreciate this information from Brandon and Joanna. This is very helpful. I would also like to say treating persons with acute or chronic pain, because part of the research here is that when someone has acute pain, I mean, this has been recommended to family practice physicians by various organizations, including family practice physician organizations for years now, is, the RICE method and whatever the updates to those are in the last few years, and anti-inflammatories, but also, utilizing these other modalities, including self-care and massage and stretching and on, is the key for even acute pain, to prevent it from becoming chronic pain, to prevent it from becoming something where higher, medication or treatments are necessary, or interventions that are costly and could have been avoided, and so forth.
So I'm listening to you, and I haven't sat in on any of your meetings, and maybe I need to, but or maybe it would be helpful. But I think we're close here, and I'd just like to take a little bit of time, make sure we get this right. It could with acute and chronic pain. Yeah, I think that's pretty close.
As Dominic, to reduce the frequency of opiate prescriptions and thereby reduce the risk of developing opiate use disorder.
And even possibly including, as it is the primary known cause or correlation for developing. That's what the data is saying here. What is it, 80% of people who develop an opioid use disorder began with a genuine pharmaceutical prescription with a medical need. So that's the point.
Yeah, not anymore, actually.
No.
Well,
yeah,
that was
that is
past
outdated.
data. I mean, that's past data, of course.
But
so I guess it's sufficient.
The other outcome that I think is really important to have in here is just the relief of pain. I mean, that's at the core of why I went to medical school.
And before we continue on, just as a note, this is really about the purpose statement. The rationale, I think, does cover those other points. But before we keep going on, Elaine has had her hand patiently up for a while. So I would like to be able to give her an opportunity to speak. So Elaine.
Okay, my name's Elaine, and I wrote the document for DOMs, and what really struck me, that this is a slightly different area of what we're talking about, but I think we really need to make sure that we're seeing the forest for the trees. The Essential Health Benefits Benchmark Plan for New Mexico states that in 2022, which we're 2/3 of the way through, acupuncture is covered at 20 visits a year, and I believe chiropractic is as well. Gosh, now where is that in the document? There is also a statement that, so I can find it real quick. Maybe I can't find it real quick. You read everything at any rate that I sent. I'm sorry to be unclear about it, but state law already states that acupuncture and chiropractic are covered by Medicaid. And it's been stating that for quite a long time. And as Michael pointed out, the recommendations that he was quoting from first came out of 2013. So I really don't understand why we still have to push anyone to do this. I'm asking this as a serious question. Being that it's already in state law, why do we still have to try to get the state to do this? Seriously, can anyone please explain that? Maybe that's the most complicated part.
I'll take a shot at it. And the real reason is because the regulations that control Medicaid are federal regulations, not state law. State law doesn't dictate how Medicaid functions. We have to have the authority from the Centers for Medicaid and Medicare Services to incorporate anything.
That's a great simple explanation. Thank you. I thought that's what I thought for.
And Elaine, if I remember correctly, which I'm pretty sure I do, they specifically took us out. Sydney, I forget her last name, but she specifically took us out back.
But the 2022 regulations include us.
Yeah,
So
I think the difference there, the reason why, in my understanding, Dr. Gooch, the reason why the 2022 regulations, the benchmark plan for the ACH includes 20 visits of acupuncture and 20 visits of chiropractic per year, mandated to be included in all plans that are sold on the ACA exchange in New Mexico, is that New Mexico has defined acupuncture and chiropractic as essential health benefits. Now, when we step back and look at Medicaid and Medicare, as Neil Bowen said, these are all regulated. You know, the whole programs are dollar for dollar match. The state puts in 50% of the cost typically of each service, is my understanding. The feds put in the other 50%, is my understanding. And so what ends up happening then is if the state goes out on its own to add these things, they're paying 100% for the services. There's no reimbursement coming from the feds. And so there has to be some kind of decision or will to do that. And that's why I think that the information that you helped compile and that Dr. Pridham helped compile in these two documents is so essential to keep driving the point home that this is very important to invest in and to follow through, hopefully, on having this added with a state plan amendment. My understanding is a state plan amendment typically has to happen if Medicaid is going to have any coverage from the federal part for the state services. Is that correct, everyone? Or am I missing something there?
I'll just give you some good news. You know, the federal match for Medicaid dollars changes from state to state, and it's based on a pretty complicated formula that has to do with the wealth of the state. And in New Mexico, we actually put in 20 cents for every dollar of Medicaid on average, and the federal government puts in 80 cents.
Sure.
And then while I'm on Medicaid, Medicare, Michael, I wanted to thank you for talking about the waiver being out for public comment at this point, and point out that, you know, when this version gets approved eventually, we will no longer call our Medicaid program Centennial Care. It will be called Turquoise Care at that point. That's new news.
Thank you.
One more thing I just wanted to add about the purpose of this proposed recommendation. Dr. Pridham, I thought that the item B, you started to have an item B, which was about, you know, helping to also treat people who have developed an opioid use disorder. So I just thought it's great that we're now starting with treating persons with acute or chronic pain to reduce the frequency of developing it, but also it's to treat people who have developed an opioid use disorder as well. I want to be clear about that. People who have developed an opioid use disorder, according to a lot of this data, are benefiting from these kinds of services as well, especially acupuncture. I believe there's data that supports chiropractic as well.
Yes.
So there's some comments in the chat as well about changing the primary or the purpose on this. Do we have more with regarding that, or for individuals from the subcommittee who can craft wording regarding that? Or again, is this something that it needs to go back for additional editing? Or
I don't think so, because Dr. Pridham, I believe that if we just, or Dominic, because I think you're editing what we're seeing right now, right? If we add back what the original document started with as B, then we are treating both primary as well as secondary or tertiary. Is basically what we're breaking down here, in my opinion. So.
Hey, you know, I just want to say for myself, I like it the way it is. I think if we manipulate it more, I'd be less likely to support it. it's beautiful as it is. I think I would like to see a motion made to accept it.
That sounds good. I will make a motion. Well, I can't, never mind.
Well, yeah, I've
That's
just made a
okay.
motion, I guess,
So,
if it's okay with the
Steve-
chair.
So Steve, you are making a motion with regard to accepting it as is at this point,
As currently, the way you've edited it.
the way
right.
it's reading currently on the screen. Okay,
Yes,
with
sir.
those edits. Okay, is there a second?
Actually, this is, I'm sorry to interrupt. This is Sharon. I do have some concerns about the overall presentation of the recommendation. It seems to sort of be a conglomerate of what was recommended in 2013, which really is quite different than what appears to be recommended today, including the title and the recommendation statement, and some work done clarifying. So for instance, under the title, it says expansion of medicated assisted treatment options, which really isn't what we're talking about. The recommendation statement talks about expanding medically assisted treatment options, which is also not what we're talking about. So I think there's been some crossing over of terminology, and I think it makes it a little unclear. So I would suggest that looking at what you're proposing as amending in the language of the statute, what you're referring to as medical assistance, which is like payment for medical services, not medication assisted treatment or medically assisted treatment. So I would request a little work be done to clarify, to make it clear as to what's being recommended. Because there's a big disconnect between the recommendation statement and the rationale for the proposed recommendation.
Would you be happy with, should consider expanding strike medically assisted and then just treatment options?
I think if you strike from after the word expanding to reimbursement options.
I'm sorry, can you say that, Sharon, can you say that again? I couldn't quite hear that.
I apologize. I'm getting a million emails and they come through as through my audio. I apologize about that. So you would strike after the word expanding in the recommendation statement down to reimbursement.
So take out medically assisted treatment options for persons living with opioid use disorder. So it would make it HSD, MAD should consider expanding reimbursement options for alternative treatment modalities for chronic pain. Perfect. And then those.
I withdraw my motion.
Thank you, Steve.
I would just like to add acute and chronic pain again, because I think that's important to add for acute and chronic pain, because again, we're talking about acute pain being a primary reason for people accessing those services.
Okay, so for acute and chronic pain. Okay, I just want to point out as timekeeper, we do still have one other recommendation after this, and we have 8 minutes left. And let me just, I just want to bring that on up because we may not get to that second recommendation from the committee. So I just want to make sure everybody understands that. Joanna, you had your hand up.
I guess I just want to say to Steve, I still think there needs to be a primary or a secondary purpose, meaning that I still would like, this committee, the title of this committee also has chronic pain in it, not just substance use disorder. And I would go to a chiropractor even if I didn't have a risk of substance use disorder. So I think under the purpose, there needs to be something separate from reducing frequency of opiate prescriptions. So I would want to go to chiropractors and integrative medicine treatment, not just to reduce my opiate prescriptions, but just to get my chronic pain treated. So I think that the purpose of the proposed recommendation should have just something solely on treating chronic and acute pain, separate from reducing the frequency of opiate prescriptions. That's just my feeling. Over.
Okay. Any other comments regarding that? And if doing so, I need language if we're going to edit that.
Put it
So
in the
let me-
chat.
Yeah, or maybe let me take a stab at it because you're making a good point. So under purpose,
I put it in the chat. It's a proposed language.
And I'm sorry, Joanna, it's difficult for me to scroll back while I'm controlling the other screen.
Yeah.
Is it possible for you either
yeah,
to
sure.
read it to me or?
It's decreased opioid pharmacotherapy, which can increase the risk of developing opioid use disorder.
That's the first one. The first one I think should be the second one. The first one should be these expenses will support the reduction in acute and chronic pain. And then the second one should be what the first one is. That's what I think. That's just my feeling.
So let me see if I've got it correct for you. Like that?
That's what I think, but it starts broadly. They will support reduction in both acute and chronic pain. And then not only that, they'll reduce the frequency of opiate prescriptions, but.
I think that's wonderful. I agree wholeheartedly, and that's what I was trying to get at earlier. So thank you so much, Joanna.
Okay, so, and again, as mentioned, we do have people who do need to drop off the call in just a few minutes. So do we have anything else with regard to this recommendation? Okay, is there a motion regarding the recommendation?
I see Dr. Hayes Roser.
I'm sorry.
No.
Dr. Hayes, did you have your hand up? My apologies.
I am just wondering if instead of alternative, we want non-medication treatments, because that's really what we're hoping for. Alternative makes it sound like maybe stuff without evidence, but non-medication treatments with good evidence, because that's what we want. And I think that's what the whole rest of the document says.
Is that Leslie who's saying that? I can't tell.
Yes.
Yeah. And Leslie, I'm sorry, where in the document are you?
In the open, the Human Service Department, blah, 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 should expand reimbursement options for non-medication, evidence-based non-medication treatment modalities. That's a little clunky, but that's what I want.
And I think non-pharmacologic, can we say non-pharmacologic as well? Because non-pharmacologic is really like what the name, part of our, council is focused on, correct? Non-pharmacologic pain management.
And then why do we have pharmacists and pharmacist clinician in there then, I'm wondering?
I don't know. That didn't work on this.
Yeah, if Ernie was on, and if he can unmute, he would probably be able to explain that. I guess back then, at least, pharmacists, clinicians weren't able to be reimbursed by Medicaid. But if you want to take off the expansion, yeah, that's what I was going to say.
There we go. And we'll just leave that one as amazing options, if that's okay, Michael.
Yep.
Okay. And so should we leave pharmacists and pharmacist clinicians in here, or does that need to be removed?
I'm fine if.
Given that we're talking about non-pharmacologic pain management, I don't understand that, but I'm not sure why it was there to begin with in 2013, because I wasn't around then.
Right, it was clunky. And
So do I take that as a yes, remove it?
Sure.
Yeah, remove it.
Okay.
I think that's in there because when we first did this, those of my colleagues here that have been on this journey together, I think we had combined two recommendations in one. We wanted to make it that more providers like nurse practitioners or PAs could prescribe MAT. but also threw in the alternative care. So I think it was a combined recommendation.
Okay, that makes sense.
Beautiful,
Yep.
thank you.
Okay, and we have 2 minutes left on this. So in our time, and I know we have other people dropping off. So at this point in time, is there a motion regarding this recommendation?
I'll make that motion.
We have Steve again for the 3rd or 4th time recommending, making the first motion. Do we have a second?
I'll second.
Neil seconding, thank you. And is there anyone in objection, or do we also consider this unanimous of those present? Seeing no objection, we have our 3rd recommendation at this time. And as much as I would like to get into the DOM recommendation, what I would like to do right now, I'm hoping people have had the opportunity to read through that particular recommendation. So what I'd like to do at this point is I'll bring it up very quickly and see if there are changes and objections. If there are, we'll need to bring it to the next council meeting, which will then need very quickly to set dates. If there are changes that need to be done to it, then we'll need to obviously consider it later at another time at the next meeting. So here we go. All right, that should be showing on the screen now. And I'll give folks a moment. And while people are reading it, I would like to say Eileen was very helpful with all of this and instrumental. And I know she had to drop off, but I hope that you're here to hear this because she really helped pull a lot of this together. And I think other members of the subcommittee will agree with that.
Very much.
Okay.
Yes, as previously noted, it's going to be turquoise care now instead of centennial. So I have to learn how to spell the word turquoise now.
Well, I think if we do pass this recommendation, I think what we can say is, we can just make sure as it moves forward that the governor's office know that we're referencing a renamed entity.
Correct.
I don't think that'll be an issue.
Dominic, could you scroll just a little bit? I think that there's a lot of data that Eileen, that Dr. Ghosh, brought together, and there's a lot of clear summary of what the current status is of coverage of acupuncture, including 16 states in the U.S. that do include acupuncture for their Medicaid programs in some way, shape, or form. So New Mexico tends to be quite cutting edge when it comes to developing and implementing, natural and integrative medical modalities, including Oriental medicine, our Practice Act being among the first in the nation. New Mexico also has one of the highest rates per capita of doctors of Oriental medicine of any state. It's in the top 95th percentile of per capita acupuncturists, also known as doctors of Oriental medicine, compared to other states in the U.S. There's also a very, long tradition of Oriental medicine in the state with very low rates of complaints from patients of any kind of injury. And again, what is being recommended here is for Medicaid to, it's a recommendation, which Medicaid and or the governor can do whatever they like with, but to bring on par for people who are Medicaid qualified, which is about 800,000 New Mexicans, the same access to care for acupuncture, 20 visits per year as the ACA benchmark plan. So people that are a little less financially challenged or impoverished, depending on the term that you like, people that are struggling slightly less financially than those on Medicaid, who have qualified for sometimes a 100% or near 100% subsidized ACA plan, have that access to acupuncture and chiropractic services, 20 visits per year of each, but those who are Medicaid qualified and on Centennial Care do not. And this is to bring that parity to make sure that we can provide non-pharmacologic pain management access for all of those who are on Medicaid at the same rate as those who are on the ACU benchmark plan.
Thank you, Brandon. That is excellent information and I think sums it up very well. Are there any comments or changes? And I'll scroll back on up to the recommendation itself. Okay, and I don't see any comments or other items. So do we have any motions for this recommendation?
I'll motion.
See, Steve, Phil beat you out on this one.
I want to give someone else a chance. I'll second it though, if no one else does.
There we go. We'll include you down as a second on that, Steve. And so we have a first and a second. Are there any other, or as we've been doing, are there any objections to passing this recommendation? Seeing no objections, we will move this one forward. There we go. Thank you, everybody. That does conclude all of the recommendations that we have. Joanna, I know you had wanted to do your little presentation. What I would, or talk a little bit about what you have. What I'd like to just do first is if we can set our date for the next meeting, and then we can actually close out this meeting. But if anybody would like to stay, we'll keep it open, and Joanna, you can provide the information if that'll work. And the reason I say we do need to schedule a little bit is usually we'd be looking at the second Friday of November. That happens to be Veterans Day. And so because of that, many locations and offices are closed in honor of our veterans. So my question comes to, should we see about doing our meeting on the 18th of November, which is the third Friday, or should we skip to December and go on December 9th, which is the second Friday in December? Is there anybody who has a preference first? I guess I will ask.
I think just with the speed that we went through the integrative pain management and we didn't touch the fentanyl stuff, I would say a November meeting would be good. I also think this was a very productive meeting. And I think, the things that we've made recommendations on, I think I'm really excited about, and I just want to make sure we get that right for the legislature and have that set by January.
And I think those are some great points, Brandon. So with that, and I see Elizabeth has put in that November 18th would work. So why don't I do it this way? Are there any objections to November 18th? Leslie, I do see you've got a CME, but you agree that sooner rather than later? Okay. Are there any other objections to the 18th or any other concerns?
I was
go ahead.
Going to suggest potentially adding a half hour to the meeting because we'll have our two recommendations and the revised ones and things happening. So
I'm perfectly fine with that. Is anybody else have an objection for doing a meeting on November 18th at a 2-hour time slot? Okay, so we will go with November 18th for 2 hours, and we will move forward with that. All right, so is there any other business that we need to address? I do know I've got a couple other text messages from people who have to drop off. So is there any other business that we need to address at this time?
Could we hear from Joanna, those of us that have time to stay on, or are we not?
Absolutely. We'll just close the meeting. What we'll do, Brandon, is we'll close the meeting for votes and all of that, but I'll keep it open. Anybody else? All right, at this point, we are now adjourned with regard to the meeting itself. We will stay open for Joanna to do her presentation and talk a little bit about the new program. Thank you. Thank you, everybody, for joining. I really appreciate it. This really was a very productive meeting, really had a lot on it. And Joanna, look forward to hearing it. And I guess I should have asked if you had a few extra minutes as well, but I apologize if I didn't. So if you don't mind, though, the meeting and the floor is yours.
Thank you. And just to take 3 or 4 minutes, And I can take any questions, and I don't have anything to share, mainly because I'm not so good with Teams so much, but I can certainly email, maybe I can email some flyers to Dominic, and he can certainly maybe send out to the group. But I am going to be launching with some really awesome team members, two ECHO programs beginning in October 6th. They are two adverse childhood events echoes for the state of New Mexico. Completely for New Mexico youth, kids, children and adolescents. We're focusing on kids ages 5 through high school. It is an external grant from the Foundation for Opiate Response Efforts, or FOR. We have a 3-year grant, and we're focusing on school-based health centers, teachers, and really all clinicians and behavioral health providers. We have an awesome curriculum, starting with kind of what is a normal attachment, what are adverse childhood experiences, what is kind of complex trauma, and then we're focusing on how to identify adverse childhood events early in order to reduce the risk of developing substance use disorder, chronic pain, mental health issues, and suicide. That, as you know, we kind of lead the country, or top in the country, for most of these 4 issues: substance use, chronic pain, mental health, and suicide. Not to mention that, gun violence is so high in the state as well. So it's launching October 6th, Thursdays, 12 noon, 12 to 1. It's not part of any direct DOH adverse childhood events program. It's separate, but we would like to kind of reach out to anybody at DOH and kind of collaborate. And the speakers are from our hub team, as well as many kind of internationally known as speakers. The first Thursday of every month, it's going to be what we're calling all hands on deck, and we're targeting kind of every clinician in the state, every behavioral health provider, every teacher. So we're hoping for a very large audience, and it's going to be much more of a webinar format. And then the second and third Thursday, we're focusing not only on, a large audience, but we're really hoping to get school-based health centers and teachers involved. And it's going to be that much more traditional didactic with the case-based format. So we're going to really try to get teachers and school-based health clinicians to present a real de-identified case about an elementary school or middle school or high school child that they're worried about, in order to be able to educate them and help them identify a youth at risk. And so I can share with you, if it's okay, Dominic, I can send you the flyers and the curriculum, and yeah, see if you're interested and see if you might want to socialize it. Yeah.
Absolutely. And just send them on over to me, and I'll send them out through the Google group so that people can.
That would be amazing. That would be amazing. And Catherine, if you want to talk offline or further, that would be great too.
Let me, what I just pointed out to Joanna when she mentioned it in the chat, we have an ACEs work group at DOH with maternal child health and injury prevention and overdose prevention that also has some representation from Behavioral Health Collaborative. Bryce has been able to drop in and out. And from the early childhood development folks, Dr. Janice Gonzalez, who I'm sure a lot of people know. And this was stood up with some Ask Those support. And one of the things that I was actually doing a couple weeks ago was reviewing an ACEs Project Echo proposal from David Selvage, who, again, people who have worked with DOH in the past may know him. But I think this is actually going to be complementary, because Some of the academic detailing ACEs proposals that we've seen from the National Resource Center for Academic Detailing, and some of what David's proposing focuses on pediatricians, not on school-based health centers, not on teachers. So I think ideally this is really going to be a great complementary, because Project Echoes are so wonderful, as you know, as we all know.
So this is an echo that you're talking about, Catherine?
This is a proposal for an echo that's in development. This is literally something that I was asked to look at, as I said, a couple weeks ago. So then when you said you wanted to present on an ACEs echo, I was like, wow, I know Joanna moves fast, but so yeah, I mean, one of the things that this work group has done is a partnership readiness assessment, which is really to try to do exactly what we're doing right here, to better coordinate ACEs work around the state, because we know we have a whole lot of people working on it in different ways with different funding sources, trying to address it in different ways. But it really is one of the biggest upstream causes of exactly what we're trying to address. So, you know, this is one of the reasons why our team in overdose prevention really wanted to be part of the ACEs work group, because we're like, this is how we get out ahead and upstream. Yeah, so I'm really excited. I'm really excited to hear about this, and I will share that info. And
please, share it right away. Share right. Is Bryce Pittenger in part of this?
Yeah, she hasn't, you know, as you can imagine with her schedule, she hasn't been able to make all the meetings of the work group, but she is definitely involved, and we really appreciate her support.
Right. Gotcha.
Similarly, Janice Gonzalez, of course, after, you know, with all of her, since she's the medical officer for ECDC.
Right.
Yeah.
So good. So good. Yeah, I'll share it all right away, and would love to just kind of overlap and share and do whatever. So yeah, that's why I wanted to just let you guys know. And I think I remember you, Arian. I think you were on a recent meeting that I was just at, right?
I don't know, which one was it?
Oh, okay. Probably, I don't know, but
can you hear me, by the way?
Yeah.
I've been listening in quietly. I just wanted to just offer a few thoughts, because this relates very much with a huge project we're undertaking right now as a state. So we are currently developing a new state health improvement plan. And we've done these in the past, but they've been largely DOH documents. I got Secretary Sprace to really approach this differently. We're involving all of the other agencies. We're involving the entire healthcare system. And it's, you know, we're doing really in-depth community health assessments right now. But the idea and the reason why I'm bringing this up to you is because ACEs is a huge part of this. What we're trying to do, and when I met with all the secretaries like a week ago about it, they got so excited, because I was telling them, like, you know, in government, we're so used to having to sort of intervene downstream. Like, we have the problems, all of our performance metrics relate to how efficiently we're dealing with like processing problems. And what if we could actually go way upstream and create this built environment together that produces